Welcome to the ATSP sort of facilitator training. So we're going to go a few things. The first thing we're going to go through is hopefully you all received ATSP last year. I do know that there have been some couple of issues during COVID and maybe not everyone has, but if you haven't, then hopefully we can go through exactly what it is and we can get it all sorted, and that should say 2021, so I apologise for not updating. We're going to go through a little bit about how the session normally runs, some ideas and teaching options for you guys. When we used to do this in person, we would do a demo, which we'll use a couple of videos for, and then go through some hints and advice and any questions that you might have for us. So due to COVID-19, obviously everything has changed in medical education in the last couple of years, and with a recent further surge in cases, I do know that different trusts have slightly different restrictions at the moment on education activities, so you are going to have to be a bit flexible with things, whether or not that means that you have to do some of it over Zoom, whether or not you can all get together and do it together, or with small groups or split sessions. And as you've attended the teaching today, the training today, then we need you to sort of lead any other volunteers, F1s that you've got sort of in that are doing it with you. So if we go to a little bit about what ATSP is in the background behind it. So I'm sure you can probably all remember your first on-call shift. Mine was nearly 5 years ago now, and I still very much remember being absolutely terrified before going on call. And really it's about helping prepare the new F1s in terms of their confidence, in terms of how well they feel in going into that job. So the transition from medical student to your junior doctor is often very stressful. You learn a lot during medical school, but you're not always sort of taught some of the things that can help you practically on the ward. So some F1s have reported feeling under-supported, under-prepared. It's obviously a very challenging workplace. You can be dealing with some quite distressing situations, patients and family. And all of a sudden you've gone from being sort of the medical student who is asking to learn and do as much as they can to suddenly having that responsibility for patients' lives. And there can be quite high expectations from patients, from family. So it can be quite daunting and scary for the first time that you do it. So ATSP was actually developed initially back in 2010 as an interactive peer-delivered teaching program, basically looking to cover common acute presentations that you're most likely to see as an F1 when you go on call. It's not about teaching them all their knowledge. They should have learnt their medical knowledge at med school, they'd pass finals. It should be more about helping them structure the basics that they would need to do when assessing a patient before getting senior help if they need it. So again, it's not supposed to be teaching them of the medical side, it's much more about teaching them how your hospital works, because once you start to move around different hospitals, what you will find is that every hospital has a completely different way of working. You've got different computer systems, different times that you bleep this person or that person, even different ways of getting in contact with the F1s. Some hospitals have it where the F1 will carry a bleep. Some hospitals have it where it's all through an online system and it comes onto a phone to something like Nerve Centre, and then some all calls are triaged by like an ACP or something before it comes through to the F1. So because every hospital is different, the main idea of ATSP is to help prepare them for what they're going to be facing at your hospital. So at med school, if we look at what med school teaches us, it's very good at teaching us the sort of GP, preventative medicine, chronic diseases, communication skills, and it's also very good at teaching us the acute things, so your A to E examinations, stuff that you'll see in A&E and cardiac arrest. But what it doesn't do quite so well is this middle bit in the middle, which is sort of more your patients on the wards, symptomatic relief, sort of supportive. So they're not acutely unwell at this time. They've been in for a couple of days, but they need reviewing and there were just certain things going on. So what we see in this sort of group are sort of the hospitalised patients, a very busy ward. They have potentially to come on very unwell. It's more subacute presentations. And often if you're on call, it can be a little bit more of lone clinical decision making. You're not on a ward round. You're the only one there and you have to call for help if you need. And it's basically looking at patient safety. You'll all know that the NHS is just getting busier and busier, and your on-calls are probably getting busier. So you actually have a limited amount of time in order to make sure that your patients are safe. And then also setting the parameters for observation and reviewing your patients, making sure that you're keeping them safe. So the way that it works is this counts as phase 1. So this is the facilitated training session. And then you, as your current F1s, will become the teachers, and you do implement phase 2, which is the ATSP teaching session to your new F1s that are coming into the trust. So you should be allocated 3 hours during shadowing and induction. That is a Northwest Deanery standard. If you have any problems, let us know, but that is what you are supposed to be allocated. And we basically suggest that you sort of do a little bit of an introduction with them, go through answering bleeps, a lot also about documentation and the fact they're lone encounters. We're not really looking at defensive medicine here, it's more looking at the fact of making sure the patient is safe and that we also protect ourselves. And then go through some of the common on-call scenarios. How you want to do that is up to you and the team that you're doing the teaching with. You can use role play, you can use interactive PowerPoint presentations, and you can have a little bit of discussion if that's the way. We do recommend that it is 3 hours is quite a long time, so it's normally quite a good idea to bring in sort of a break part way through and bring some treats, some chocolates, things that we all like that get us to any sort of teaching. Okay, so when we're looking at answering bleeps, so going through with them reason for the bleep, getting the background, thinking about the clinical information, and so getting them to sort of talk to you about what they need. Other things that can be helpful is going through them with them, getting them to ask what else they might want. So when they're answering the bleep, is there anything else they might want the nurse to get ready? So if your hospital is still on paper prescription charts, then and paper notes, then getting the notes and getting the prescription charts ready. Is there anything that you want to do? So if they're going to need a cannula and things, asking them to get all that ready, because when you're particularly overnight, you're covering multiple wards and it's not a ward that you're very familiar with, you might not know where anything is. So if they can have that all ready for you, that's going to save you time and mean that you can get things done. And then also any other actions or procedures. So could the nurse do an ECG for you by the time you get there, and those types of other things, or could they get a urine dip, could they get some bloods? Obviously it will be dependent on the situation, but what can they do to sort of help? You need to talk a bit about prioritization. There are often lots and lots of jobs that need to be done, and they need to be able to sort of work out which ones are higher priority. Accessing senior help. So again, this is different trust to trust, who you contact, how you contact them. And then also showing them what can be really, really helpful is showing them where to find local policies. So all hospitals will have slightly different policies. And I can remember trying as an F1, one of the most helpful things I found out the session was actually being shown where to find everything, so that they weren't in the middle of the night when I was going, I know there's something on that, knowing where to look can really help. So showing them, going through anything that also might be specific to your trust that you might have heard is different elsewhere. For instance, the trust that I'm at now, if I want a CT overnight, I don't have any issues. I can give them a call. I can give Everlight a call, and they don't need a senior, they don't need a consultant or a registrar to authorise it. I can request that as long as I've discussed it with the radiologist. But when I was in F1, it would have to be a registrar or above that had made those calls and requested those types of things. So it is important for them to know what the policies, how it works at your hospital, because it's not necessarily that they don't know how to manage the patient from a medical point of view, but they don't know how to manage the patient from your hospital and the location environment point of view. We then go through a little bit of a systematic approach with them. So eyeballing the patient, talking to the patient, is this patient well enough that you can go and have a look in the notes quickly, or is it one that you are going to be going straight away? Again, systematic approach with your A to E. Have a look through notes, medications, look at the results, and put it all together with a problem list and plan of action. From a documentation side, again, we're focusing on the fact that we are on call, you are often lone encounters. Again, emphasising that it's not that we're wanting you to practice or encourage defensive medicine. It's more about making sure there's safe practice. So it's things that maybe they don't really go through all the time with you in medical school, in terms of if you've setting parameters and things for a patient. So you've seen a patient, you've got a plan, but setting parameters for nurses to call you back if there's concerns. So if this happens, there's a recontact for review. If this happens, do this sort of thing. Just so that they've got that there, so that they, and being specific, because again, the same way that you are, they will be brand new F1s. They may have brand new nurses. They may have nurses that have been there for 10 years and know exactly what they're doing, but they may have newly qualified, but just need that little bit of extra guidance of what they want from them. So an example that we've got from the booklet is blood and catheter bags. So you can see that we've set it out in an A to E manner. And again, this is just a guidance for them. They don't have to follow this. It's just a way to help them sort of make sure that they're not forgetting things, and just in a sort of systematic way. So all of the booklet will be laid out like this. It will have an examination A to E section. It will then have a bit about investigations, history, medication review, and then plan. And again, this isn't supposed to replace any local guidance, and we really want you to stress that. This is not, if you have local guidance that says something else, you cannot document as per ATSP booklet. This is just an aid. They need to make sure they're following their local guidance. And again, it's about those steps they can do before they call for their senior help, before they're calling for their reg, or they're calling for someone else to come and see, so that they've got the basics sorted. So these are the current scenarios in the booklet. So these have been developed over a number of years with, when talking to F1s, what they want in. If there's anything that you can think about that you particularly think we are missing, or it'd be really helpful, please let us know. But these are often common things that you might need be called to see over your on-calls. In terms of teaching, as I said, it is very much up to you. These are your teaching sessions, we're not prescriptive. You can use role play. Role play particularly works well in the sense that it does tend to engage the whole group. You can use props. So if you are still using paper charts, paper news charts, prescription charts or anything, bringing those in so they can have a look at them and become more familiar is really helpful. And you can use things like mannequins and things if you've got that available to you. Obviously, it will depend very much trust on trust, what you have and what you can ask for. Okay. So a little bit, very briefly, I'm only going to touch on this briefly, is a little bit about the educational theory behind what we've been doing. So the idea is that when you start out as a new F1, you are in the incompetent, unconscious box, which is often that you're not aware of things, of skills that you lack. You're brand new to the hospital, you're not aware that you don't know how to order this or how to get this or how to do that. And then gradually, as you've gone through the year, if you hopefully by now you have gone through and you're at the point where it's unconscious competence, at the end of F1, you're probably doing things on call now that would have taken you quite a long time to think about and consider when you first started. So we're trying to sort of help them a little bit and move them further along at an earlier stage. So again, this is the same sort of thing. So imagining them as the brand new F1s or a novice, and you by comparison are the expert at being an F1 because you're coming to the end of your year, you've been doing it for a year. You guys know better than I do at any of your hospitals how to do your job. And so that's the idea behind having it peer-led, that actually the committee, me and the rest of the committee could stand up and do sessions to new F1s, but actually we're not going to know how your hospitals run the way that you do. We're not going to know about necessarily changes. We might have been F1s at your hospital, but that for me was 4 years ago. So you are the best placed people to really help them as they start out on their new career. And so if we look at sort of this slide, at medical school, they were really taught sort of how to remember and how to understand. So they understand a lot of the medical things, they remember lots of facts. And what we're really trying to do with this, with ATSP, is help them apply what they already know and into the situation they're going to be, and hopefully getting to the point where they can start analysing things as well. So it's just moving up that pyramid of learning. Looking a little bit about this is a 70-20-10 model of learning. So that does show you that about 10% comes from formal classroom training. So that's what they've done at university. About 20% comes from sort of watching others. So some of that will have been while they were in their clinical placements. For those that have come from unis that do an apprenticeship, that do their sort of finals in 4th year, that will hopefully have been most of their 5th year, that sort of informal observing, slowly doing more and more. But you can see that the majority of knowledge actually comes from doing the job. And so if we can give them a little bit of a head start, and we can help them with that, then hopefully they'll feel more confident going into their own calls. And again, when you're using the 70-20-10 model, it needs to be relevant to their situation, capable, being applied to experience, and then again delivered by a teacher with validity. And that's where you guys come in, because you are their most near peer and have done the job most recently, so you know better than anyone else what they need to know. When we're thinking about the teaching sessions, we just give you some advice to try and think about the fact there are lots of different learning styles. So some people are verbal learners, some people are kinesthetic learners, and just think about using different techniques of learning to try and engage all the different learners that you might have in your group. So using a mix of different teaching techniques to try and incorporate and appeal to as many of them as you can. A little bit about giving feedback. So as I said, we're not there this session isn't designed to test their medical knowledge. And one of the things that we really don't want to do is to quiz them, to grill them, to make them actually leave the session feeling more nervous and feeling like they don't know anything before starting. The idea is that we're wanting to sort of build them up and build their confidence and help them sort of put what they do know into sort of a more practical way of thinking. So when we're giving feedback, you can use, there are lots of different theories behind feedback. The one that we have chosen more is Pendleton's rule of feedback. So getting them to say what was done well, and then you can sort of feedback on what you feel was done well, getting them to say actually how they could improve things, and then you stating how you think things might be improved, and then coming to sort of a consensus between what could be done moving forward. So I'm just going to quickly have a look at any, she says, stop share, questions at all. If anyone's got any questions, I can't see any. So I'm going to carry on for now, but I will double check the chat in a little bit to see if there's anything else. So prior to COVID, we would normally do a little bit of a demo for you. There would be a few of us, and then we get you to practice yourselves. Obviously, things are a little bit more difficult since we moved online. We don't really have that ability. So what we're going to do is go through a scenario and show you some videos that we've recorded to sort of try and demonstrate that. So we're going to use abdo pain as an example. So it's 10 o'clock on a Thursday on a respiratory ward. We've got a 43-year-old female transferred from ITU 4 days ago after a road traffic accident. She's got a resolving HAP and no medical problems. So answering the bleep is what we're going to go through first. So again, we would recommend using, if you can, role play, but you can go through other methods if you want. So reason for the bleep, quick background, getting further clinical observations as we've gone through, instructions, prioritization and senior help. The key thing is make the group work together for the information and make sure they teased out all of the relevant information before you move on to the next stage. I'm just going to quickly stop sharing that one and start sharing. So I'm hoping this is going to work. If it doesn't, please let me know.
I can't hear anything.
There's no sound.
There's no sound. Okay, sorry. Hang on a second then. Oh, thank you. Why is there no sound? This is when I would normally need my techno. Sound now?
No, when you share your video, there should be an extra button that allows you to share sound
Oh, thank you.
from your device.
Thank you so much. Right, we'll try that again.
Yeah.
You got sound now?
Yeah.
Hello?
Hi, it's the F1 on call. Did someone brief me?
Hi, yes I did. I'm one of the nurses on ward 6X. I need you to come and see a patient straight away with chest pain.
Oh, okay. Can you tell me some more about the patient? Why is she in hospital?
Hang on, I'll get my handover sheet.
Okay.
Okay, yes, so she's a 65-year-old lady with pneumonia admitted yesterday for IV antibiotics.
Oh, okay, thanks. Does she have any other medical problems?
She's got GORD and diabetes.
Okay. What are her observations like right now?
Right, her SATs are 98%, rest rate is 18, her blood pressure is 130/85, heart rate is 90 and temperature is 36.7.
Okay, so she seems quite stable at the moment then. Is that without oxygen?
Yes it is, yes.
Okay. I've got someone else to see first who I think is probably a bit more urgent. So whilst I'm getting on my way, will you just get her notes ready? And would you be able to take some bloods from her and put a cannula in, please?
I'll try. It's only myself and the HCA here, but I'll try my best before you get here.
Okay, I'm going to need to do an ECG since she's got chest pain, so if you could get the ECG machine nearby and I'll try and do that as soon as I get there.
No problem, we can do that for you.
Okay, so I won't be too long. Oh, before you go, can you just tell me her full name and her date of birth, please?
Yes, it's Mrs. Louise Smith, and she is the 1st of December 50.
Okay, and which bed is she in?
She's in bed 1 in bay 5.
Okay, thanks very much.
Lovely,
Bye.
thank you.
Okay, so we'll just go through that little bit in a second. I realise I probably should have done the other one first. So that would be ideal, really. They've got all the information that they needed from. Yeah, I'm going to stop sharing a second. They got all the information that was required and they needed. But obviously, you're not necessarily going to get your brand new F1s to do it like that the first time. So what you might find is that you get some that's more like this one.
Hello?
Hi, it's the F1 on call. Did someone bleep me?
Possibly, let me just go and find out.
Thanks.
It's the
F1 on call, did you bleep her?
Oh yes, thank you. Hello?
Hi, it's the F1 on call. Did someone bleep me?
Hiya, yeah, it's one of the nurses on ward 6X. I need you to come and see my patient straight away. She's got chest pain.
Oh God. Okay. What's her name? I'll be there right away. Okay. Bye.
Okay, thank you.
So Alison, how do you think that went?
I don't think I dealt with that one very well. I was panicked because she said that the patient had chest pain, so I thought I should try and get there very quickly. But I realised I forgot to ask the patient's details.
It's easily done, isn't it, when it's scary, when you get a bleep like that?
Yeah.
So apart from asking for the patient details, what other things can anyone think of that could be done differently?
So I think it's really important to get a basic observation of the patient, because that will enable you to prioritize your patient, and basically you know, it might even be necessary to put a med call out, for example, if the patient really acutely unwell.
Yeah, absolutely. So it helps you prioritise your jobs then, doesn't it, if you've got that information?
Going through SFAR handover and getting a background, getting some context of what's actually happening with the admission.
Brilliant. So has everyone heard of SFAR before? Yeah. This is a really useful tool to use when you're answering a bleep because it should give you all the salient information. So should we go through what SFAR stands for?
Situation,
Yep.
background, assessment, and a recommendation.
Absolutely. So in this situation, you'd want all the basic details to know which patient you're going to, where they are, and then you want the information that we just talked about to help you prioritise. A bit of background helps to put that all into context, doesn't it? And then what do you think about the R part of the SFAR, the recommendations? What might you think to do differently next time?
You could ask the nurse to get her notes ready, or if you need to do a cannula and some bloods, you could ask them to do that.
Absolutely, because we're all part of a team, aren't we? And we're all working together, so as long as you ask nicely and politely, there's no harm in utilising the team to help you get the jobs done quicker.
Or even an ECG, for example, in this case, which was chest pain.
Absolutely.
That would basically facilitate the movement.
Yeah, that's great. Super, well done.
Okay, so that's the idea of that one, is that you can see that they didn't have particularly get much information from the bleep, but then it's how you get the rest of the group to sort of tease out what they should have done. Whereas you might have had a good one, in which case your feedback might be
Alison,
like
how do you think
this.
that went?
So I think that went better. I asked for the SFAR handover style from the nurse. I wanted to know why the patient was admitted, and she gave me more information, so that was useful.
Brilliant. Any other feedback from the rest of the group?
Yeah, in accordance with SFAR, we got the context of the admission.
Definitely.
And also we managed to get some basic observation for a good assessment of the patient, and which is really important to trying to help us prioritize the jobs.
Definitely.
And she asked the nurse to get things ready for her to save time. So when she got there, so she said, can you get all the notes ready? Can you try and get some bloods and get the ECG machine? So that when she gets there, she can see the patient and manage quicker.
Agreed. Very slick. Well done.
Okay, so those are just a couple of examples when it comes to the bleep. I'm going to stop sharing that one. I'll go back to sharing. Nope. Oh dear. This is where I do apologise. It'd be easier if I had more people. Okay. So once you've gone through the bleep with them, move on to the situation. So again, as I said, we've spoken about earlier, sort of making them use a systematic approach so that they can then use all the knowledge that they already have from medical school in a systematic manner to go through things. So eyeballing the patient, reviewing your A to E, looking through the notes, looking through the computers, putting it all together and getting the plan of action. So for instance, for abdo pain, it might be they potentially having loose stools. So do they need stool cultures? Is it that they're actually constipated, which was causing the abdominal pain? They need an enema, or laxatives, or changing sort of pain relief. So opioid based to more PRN, and then keeping a plan for the future. So repeating the bloods in the morning. Just going to go to the other videos quickly. So what we're really trying to show in the next one is that actually having a look at you might encounter quite a few different types of new F1s, and how you manage a group dynamic, because when you're doing any sort of small group teaching, it's always really important to manage the group so that everyone is benefiting. So we'll just have a quick look.
Now you've arrived on the ward, you're going to go and assess the patient. What would you do?
Let's quickly eyeball the patient and then move on to A2E. Let's check the airway, make sure the airway's secure.
Absolutely, yeah. What would you do next?
And then we can just listen to the chest, make sure the breathing is okay, check the respirate, check the SATs, make sure the chest is clear.
Brilliant, yeah. So Alison, for C, what might you like to do next?
For C, we could listen to the chest, the heart sounds,
Yeah,
and check the blood pressure and the pulse.
absolutely. Anything else you might like to do while you're still on C?
Could do some bloods and a cannula.
Yeah, definitely. Anything else in the assessment that can be helpful?
A capillary refill.
Yeah, excellent. Well done. What comes next? Kushan, would you like to tell us what you do for D?
I mean, we've already done this in medical school, haven't we? I mean, obviously it's A2E assessment, isn't it?
Yeah, that's correct. So that's a very valid point. But the idea of the session is to help you use what you learn at medical school in a practical scenario when you're on the ward. So it's
Okay.
really helpful if you can engage with us and join in.
Okay, fine. So yeah, I will check the GCS.
Yeah. Anything else you might like to do for D?
Not really. Can I think of anything else? It's quite obvious, isn't it?
We
Just
could,
an A2E assessment.
we could make sure there's no abdominal tenderness.
Yeah, excellent. So it might seem obvious now, but sometimes at 3 o'clock in the morning it can be a little bit harder, can't it? So I think it's really good to recap. Anything else that you might like to do? Do you mind putting your phone away just while we're doing this?
I'm actually checking guidelines
Okay,
about A2E.
that's really good stuff, but I think that'll be better done later. So while we're all here together, do you mind just popping your phone away? Thank you very much. So if you came to E, what would you do?
You could check the temperature.
Yeah, fabulous.
And let's do a BM just to make sure they're not hypoglycemic.
Brilliant. Really good stuff. So you completed your assessment. What might you like to do after that?
Call the consultant.
Okay, so depending on what hospital you're in, the way that you escalate to a senior will be different. In this hospital, if you were on call on a medical ward, your first port of call would be the medical registrar, and it's a very good idea to bleep them, let them know about a deteriorating patient first, and they'll be the first person to respond to that in a senior way.
Even if that's the junior registrar, like an SC3.
Yeah, absolutely, and they're usually on the same bleep 5130, so if you're on call and you want to escalate, you want some senior help, bleep that number and you should be able to get through. If after that you feel you need to escalate further, you can always call the consultant on their mobile, but I would certainly discuss with an immediate senior first. The other thing that's really important to mention, does everyone know how to put out a MET call?
Obviously.
Yep, that's right, so same in this hospital, 2222, if you think the patient's unstable and you need help immediately.
Interesting.
So during the sessions you may encounter lots of different FY1s and they might approach the session differently. We tried to show you in the video a few different types of problems that you might encounter during the scenarios. So Alison was...
I was a shy F1 doctor who didn't really want to contribute much and was lacking quite a lot of confidence, so I relied on my peers to contribute in my place.
Okay, so Hayley, how would you deal with someone that's not really participating, is a bit shy?
So it's about being encouraging really, giving them some positive feedback to start with maybe, talking about what they've done well so far and giving them lots of encouragement. And then if they're still really struggling, you can have a little bit of a think about spoon feeding them some of the parts of the structure. So for example, say, what would you do for A? What would you do for B?
Okay, and if we bring Josh in, okay, so
I was a very talkative, over-enthusiastic, and a bit of a know-it-all really. Wanted to show everyone that I was confident, I knew what I was doing, and I liked answering questions.
okay, so it's a different type of challenge. How would you approach this type of doctor?
So you're going to meet lots of different personalities and you will find that some people are a lot more talkative than others. So by all means let them start and let them have a chat with you, but if you're finding that they're dominating the conversation, then ask to go around in a circle, try and name people individually to move on to. And whilst being encouraging and positive, just try to ensure that they know that they can't speak the whole time.
Okay, and then for Kushan, we had the final example in our scenario.
So I was trying to be the rude FY1 that basically was not engaging with the scenario, was on their phone all the time, and was coming across really quite abrupt to the facilitators.
So this is probably one of the more difficult ones that you'd have to deal with and has to be dealt with quite carefully because it can go wrong.
Definitely. So we hope that you won't come across too many trainees like this. But if you do, I think it's really important to try and remind them why they're here and the whole point of the session. And ultimately, even the most senior doctors have got something new to learn. So just trying to remind them of that. And it's great that they're confident and it's great that they've got lots of information. So by all means, give them some praise and positive feedback, but make sure that they're not being too cocky or too confident, because that can of course be quite dangerous on the wards.
Okay, and then we're just going to have a look at an example of one that's hopefully gone a little bit better, which is how we hope the majority of yours will go.
You've arrived on the ward, you come to see your patient. What would you do next?
So I would go and ask the nurse initially, say, hi, I'm Alison, I'm one of the doctors. I've come to see Louise Smith. Is she your patient?
She is, yes. This is Louise. She's a 65-year-old lady that came in with a pneumonia. So we're treating her with IV antibiotics at the moment. But I've called you because I'm a bit concerned. She's saying she's got chest pain.
Okay, so I would go and see the patient. Hi, is it Louise Smith?
Hi, yeah, I've got this really bad pain in the centre of my chest.
Okay, is it okay if I call you Louise?
I actually prefer Sheila.
Okay, Sheila. Can you just confirm your full name and your date of birth for me, please?
Louise Sheila Smith, 1st of the 12th, 1950.
Okay, and then I checked I've got the right patient.
Brilliant. What would you do next?
So I'll just continue the consultation with the patient. So Sheila, could you tell me a bit more about the chest pain? When did it start?
Started a couple of hours ago, really. It started quite gradually, didn't really notice it initially.
Okay, and where about it in your chest is it?
It's sort of to the middle, or maybe over to the right a bit more.
Okay, and does it travel anywhere at all?
No, it just stays where it is.
Okay, and is the pain continuously going since the last couple of hours?
It sort of comes and goes a little bit. It's much worse when I take a breath in.
Oh right, okay. Have you got a cough at all?
No.
Okay, you're not bringing any sputum or any blood up?
I was when I came in. I was coughing up lots of stuff when I came in, but I haven't today at all.
Oh right, okay, right.
Brilliant. So you've taken a bit of a history recap, which is great. What would you do next?
So let's just glance over at the observations and let's go straight on to our A3 assessment.
Excellent.
We'll start with A. She's quite clearly speaking, so her airway is secure.
So moving on to B, then obviously we've got some observation running. Her saturation is 94% on room air, and I'm just going to have a listen to her chest. Is it okay if I have a quick listen to your chest, Sheila?
Yeah, that's fine.
Okay. Are you able to lean forward at all?
I've really got bad pain in my back.
Alright, so I'll try to examine from the front then. Okay, that's great. Sheila's got equal air entry bilaterally.
And then moving on to C, I would check her pulse, which I can see over there is 116, so I just have a feel of her wrist as well and check that that's regular. I will check her blood pressure, which is just been done and it's 96/59, so slightly on the low side. I'll check her capillary refill as well, which is less than 2 seconds, and then I'd also have a listen to her chest for her heart sounds as well, which are normal.
Great. What's next?
So for D, disability. So we'll shine light into her pupils and check her capillary reflexes. She's GCS 15, I presume she's moving her arms, she's speaking and her eyes are open. I'll also have a quick feel of her tummy as well, to make sure there's no abdominal tenderness.
Great.
I'll then move on to E, which is basically, I'll just ask the nursing staff, would it be okay if we just get a quick BM from Sheila? And I'll just have a quick look at her legs to make sure that she doesn't have a swollen calf or any pedal edema.
Brilliant. Anything else that you'd like to know?
Well, we should probably do some blood tests, or any recent blood tests. So she doesn't have a cannula at the moment, so we could ask the nurse if she could put a cannula in, or if not, we can do that ourselves and take some bloods.
I also wonder if the ECG has happened, that we've asked for it before or not.
Given her acute chest pain and then deep deterioration, I think an ABG would be a good idea as well.
Excellent. Super.
Thanks.
Should we talk a little bit around feedback and what you think went well and what didn't go so well? Yeah. Would you like to start?
Yeah. So the nurse was really helpful. So when I arrived, the nurse was by the bed and managed to check that the patient was the right patient and do a quick initial assessment. Obviously, after looking at her and seeing what her symptoms were and taking a bit of a history from her, so that was good.
So I think this exactly goes back to getting a good SPAR from the nursing staff initially, because by the time I arrived to the ward there was already an ECG and the cannula was in, so I could just put my focus on the patient and basically try to examine her appropriately.
Yeah.
Eyeballing the patient, we came in, she was speaking, her eyes are open. We knew that she is sick, but at the moment, from what we can see, she's stable.
Yeah. And then you ran through that useful A2E assessment, didn't you, which was really good. How do you think that went?
I think that went quite well.
So this is that was we'll finish it there, sorry. Right, stop sharing that one. So you may not have access to a simulation suite. Obviously for your training, we don't expect you to all have access to that. It's really a case of using that sort of thing and however the idea is behind it and doing it however you can do with your whatever setup that you've got. So again, just making sure that at the end of the scenario, we go through all the important points for that scenario. So for abdo pain for the patient that we would speak about initially, so if there's post-ITU, so would have probably been on some strong opioids, might also be hypokalemic, thinking about your analgesia ladder, and then making sure that we go through all of the important points. Now in your session, it is 3 hours, but you will not have time to work through all of the scenarios. There are too many. However, we do ask if you can try and discuss all of the key learning points from each scenario, but only go through the ones that you think really are most important and you feel are most helpful in detail. So those are the current scenarios. And as I said, whichever ones you think will be most helpful to your new F1s. Now I'm going to quickly have a look to see if there are any questions. No, perfect. So this last little bit won't take too long. So a little bit of tips and tricks. Okay, so before the session, find out what room you're getting. Think about your environment. Is it too hot, too cold? Is there aircon? Hopefully we'll have a nice summer this summer, but that might mean that the room's quite hot. You might need to make sure that there's water, windows open. Think about having a break. As I said, 3 hours is a long time, so having a break with some snacks is always quite helpful. Trying to target several different learning styles in whichever way you do it, and then working together with your timings. I remember I received the ATSP when I was in F1, taught it when I was at the end of my F1, and one thing that we probably didn't do actually as well in hindsight was we all ran it separately, so we all each had a different scenario in little breakout groups, but timing was a bit of an issue. Some took a lot longer than others, so try and work out your timing with each other. Again, it's about being practical and doing the job. It is not a test. We don't want to be scaring them. And also be engaging. Anecdotes can be helpful, but again, try not to make them so terrifying that they don't want to go on call. And one of the key things is to prepare with your other teachers how you're going to do it, what you're going to do, so that the session runs smoothly. During the session, thinking about how you present and your body language. If you are disinterested and bored, they will also switch off. Again, work out before who's going to lead what. As I said, anecdotes are helpful, but try not to make them too terrifying or too scary. And then making sure that you are engaging all of them, so asking questions key things, as we said, that we like to say is how to access the local guidance and also how to use the resources available at your hospital. So good teachers, which we hope you all will be, put learning into context, are stimulating, work interactively with each other and also with the learners, display enthusiasm and interest in the subject, and also can be a little bit flexible and a bit patient. And you will, I'm sure, be able to demonstrate your knowledge with no problem at all. So there are a few things that we do ask you to emphasise. So the first thing is this is not teaching them medicine they already know. And ATSP, including the booklet, is not a substitute for senior advice. It is there to help them guide things they should be doing maybe before they look for that senior advice. And again, you need to emphasise that local guidance are available and they take precedence over the ATSP booklet. It said it's just a guide for actions before calling a senior. It was started as a patient safety initiative. Documentation, again, is a key part. And again, it isn't exhaustive. They are going to see so many more things on call, but these are the ones that we felt were the most common, and also the ones that people tend to get the most anxious about. So a little advice for the session. So as said, it is completely your discretion how you do it. However, we have found that having done it for a number of years, role play does work very well because it helps to involve all of the group. We do highly recommend doing the dying patient because that is something that's often not really seen as a medical student. Directing them to the local guidance and basically thinking back to when you first did your on-calls, what would have been helpful for you to know before you started? What do you wish you'd been told? What do you wish that you'd known? We'd say, so what we will do is after the session, we will send you out all the scenarios, and we have already developed cases for them, so you don't need to create them for each of them. You can if you want and create your own scenario, but we will send you out information that has pre-planned cases for you, just to take that little bit off you. Have a plan and try if you can to practice with your fellow teachers beforehand. So the website is on the screen at the moment. It's asktoseepatient.co.uk. And that is also where they can download the booklet from. We used to do paper copies, but we've actually found that having it online, more people preferred, and it means you're not having to carry anything around in your back pocket. And so you can contact us on the email address there, ATSP Live. Please do send us any feedback forms. We will give you a feedback form for the FR1s to complete. Once you send that back to us, we will then be able to issue a certificate to say that you've completed the teaching session. So you get 2 certificates for ATSP. You get one for attending the session today, and you get another certificate if you deliver the session. Because we do understand that obviously clinical things can change. You're not supposed to be on call. Someone's sick, you have to go on call. All those sorts of things can happen. As long as we will also send out the ATSP material, so that will include a PowerPoint presentation, cheat sheets, a PDF of the booklet, and some hints and tips. And the main thing is really to enjoy the session. One other thing that we don't normally put in here, but we have decided that we just want to mention today, is often your on-call shifts might be overnight. They're often long shifts, they're often tiring. And unfortunately, one of the reasons that I'm doing this alone today is that we have had a colleague of mine that I was an F2 and F1 and F2 with, unfortunately, after driving home from a night shift, fell asleep, crashed the car and didn't survive. And so other people that were supposed to be doing the talk with me today, we've all been at the funeral, and they're travelling back to their accommodation, so aren't able to give a hand today. So one thing that we would like you to stress is the importance of making sure that they are well rested, they are looking after themselves, they are looking after their welfare, just to keep everyone safe. Okay, so just going to have a quick look. If there's any questions at all, if you can put them in the chat or put your hand up, if I can work out how to see that. Anyone got any questions at all for the session? No questions? Anyone still there? Okay, yeah. So what I'm going to do now is just quickly put in a link which has basically the feedback form for this session, but also once you complete that feedback form, it will then allow you to download your certificate for attending the session today. And as I said, we do it in two, so you get 2 separate certificates. You'll be able to get the one for attending the session, and then once you've given us the feedback from your F1s, we'll then give you your other one. So that's the link going in now. So if you click on that, that should work fine. Thank you very much. Any other questions at all? Okay, got one question. Should we focus mainly on, hang on, scenarios coming to both medicine and surgery? Obviously people will start on both medical and surgical jobs. Yeah, I would try and focus on ones that are sort of common, because just because you've got a patient that's coming with a surgical problem doesn't mean they won't get then short of breath or high news. Try and focus on ones that are common as much as you can. But as I said, actually, one of the things I found is that often they'll come in with one thing and then end up with something else. So what I would say is it's your choice. We're not prescriptive with this. We just say if you can try and run through all the learning points of all of them, but the scenarios that you choose are up to you. Which ones do you feel would have been most useful for you when you started? Which ones would you like to take going forward?